Our first speaker this morning is Dr. Raymond Sawaya, who is the founding chairman of the Department of Neurosurgery at the University of Texas MD Anderson Cancer Center since the department was established in 1990. He is the past director of the Brain Tumor Center, also at MD Anderson, and as well as professor and chairman of the Department of Neurosurgery at Baylor College of Medicine from 2005 to 2014. He has received many awards, including the Joseph Evans Award in Neurosurgery at the University of Cincinnati, the Ann Brooks and Anthony Bullock Award, and the Charles Wilson Award from the National Brain Tumor Society. From our faculty at MD Anderson in 2016, he received the Charles A. Lemater Outstanding Achievement in Cancer, and that is the highest award bestowed by our own institution. Dr. Sawaya is a noted leader in the field of neurosurgery with particular expertise in improving the accessibility and treatment of primary as well as metastatic brain tumors, and is widely recognized for his efforts in improving safety of brain surgery. He will speak about the challenges as well as the innovations in the technology and research which are improving the treatment and outcomes of patients with brain tumors. Dr. Sawaya.
Well, thank you, Alma, and good morning. This introduction sounded too serious. I need to loosen you up a little bit. So first, to Susan, congratulations on 30 years of this activity and all the volunteers that are here and in the past who have helped. So what I thought I would do, we have obviously wonderful speakers. Dr. Litton will, I'm sure, tell you about clinical trials and some exciting new things. Dr. Futreal, or Andy, just to keep it casual here, is a top leader in genomics. And, genes and mutation is really what drive cancer. So we're going to hear wonderful things that are very informative. What I thought I would start off with, my field, as you heard, is brain tumors, but I want to use developing a comprehensive, multidisciplinary, integrated program. It happens to be for brain tumors and neurological tumors, but you will see many of the principles I will share with you can be and are applied to almost every other program at MD Anderson. So I hope it's informative. There will be specific patient cases that I will share with you. So moving forward, so again, the emphasis is beyond silos. Because we in the medical field, we tend to, hide in our own building, in our own area. I'm surgeon within surgery, medical oncologist in medical. That will not solve cancer. And I'm sure you all understand that. Those of you who had treatment or your family members, you've seen the number of specialists you've worked with. So beyond silos, how can we put together a multidisciplinary, truly integrated program? And that's really what I want to share with you. And I will, I'm not bragging, but I will say I've been at Anderson almost 30 years, 28 years to be precise, and I've helped build this program. So I really have been involved in it, and so I am sharing that experience with you. So, okay, this, of course, thank you. This is a 30,000 feet view that shows you what happened over the last 40 years in relative survival rates for brain tumors. These are mostly primary brain tumors, tumors that originated in the brain. And what I want to share with you, especially the green graphs, is back in the mid-70s when I was a resident in neurosurgery. 1 in 5 brain tumor patients lived 5 years. 1 in 5. Now, of course, many died within 1 year. What happened over 40 years, billions of dollars in care and research and advances and technology and some of the stuff I will share with you this morning, is we've moved up to 1 in 3. So yes, the glass is half full. There's clear progress, 1 in 5 to 1 in 3. So 2 patients out of 5 now are able to live 5 years and past. But this is far from sufficient, right? We want cures. We want everybody to live past 5 years and past 10 and 50 and whatever. So this, I think, depicts the real life story. Tough problem. A lot of work has gone on. Progress is measurable and real, but we are not where we want to be. So I think this is a real story about my field, and I know it applies to many other cancers, pancreas, liver, and you name it. So how do you deal with that problem is what I want to share with you today. So I want to start with this one patient. His name is Anthony from Austin, Texas. This story dates back to 1994. And Anthony was 15 years of age. He had this tumor, and I don't need to point out to you the tumor. It's an egg-shaped, egg size in the center of his brain. His father is an anesthetist in Austin, so he's connected to the medical field. He found him a neurosurgeon who operated on him. And what the neurosurgeon did, and I'm sorry I can point only on one side, I'll go back. What the neurosurgeon did, he went back here, which is a standard approach, got a biopsy of this tumor. During surgery on frozen section, he was told it's malignant, and he couldn't get the tumor out. So he closed, went back out, told the parents, father and mother, that this is a malignant tumor, it's inoperable, and he said, don't let anybody touch your child. Now, I use that example because it's so real and so paralyzing. And so he came to Anderson, received excellent oncology care, radiation, chemo, but this tumor kept growing. This egg shape get bigger. This kid, his face was, I'll show you his picture, became this big from the cortisone steroids he was given, and he couldn't see living this way. And his parent refused a neurosurgical consult because of what that surgeon told them. You don't blame them, but why do I use this case is because it really does take a center of excellence, a place where problems of this nature are seen on a regular basis, even if it may be a rare problem, are seen on a regular basis. There's experience, there's expertise, there is a way of thinking that doesn't give up, that always looks for the solution. And so I looked at this. Finally, Anthony, age 15, convinced his parents that he cannot live this way, and they allowed him to come. It happened, they saw me at the time. And so what you see, and again, from a neurosurgical standpoint, this would not be the approach because it's too narrow. We have a way of coming to it from above. And now I will not spend too much time. There's technology, navigation, GPS, indicating to me how to get in. Got in, beautiful circumscribed tumor, incredible anatomy, and I don't want to belabor the point. And here's the tumor before surgery, here's the tumor after surgery, completely gone. And here's Anthony. Anthony came back 6 months later, that picture on your right, I didn't recognize him. Off steroids, his hair grew up, his face thinned. Now, the reason I can share that story with you is his neighbor in Austin is a journalist. that worked for the Austin Statesman, their local journal, like our Houston Chronicle here. And when he heard his story, he was moved and he wrote up his story. So his picture, the one on the right, is on the cover of their local news. So it's public knowledge. He's alive today, free of cancer, free of disease. So, yeah. So that's the point, is these are tough problems. And they have to be evaluated, assessed by centers of excellence that have seen, that have dealt, that have the big picture, and that will not back away from tough problems, because all life is filled with tough problems. So moving forward, and I told you I want to tell you about the building of an integrated program. What are the principles? What are these foundations, these pillars on which you can build a structure that will be not only strong but will last? And so there are 5 issues here, and again, it applies to practically all cancer programs in our institution. Patient volume, I will tell you what I mean by this. Technical challenges, you just saw an example, a true technical challenge, and there are many, many others. Issues of curability, I showed you in my first slide. Most patients are not being cured in my specialty, and so what a challenge is this? So what a terrible problem, but what an opportunity it is to move forward. Multidisciplinary organization. There is no one specialist that can solve these problems. It's only when we all come together, each of us in our specialty, bring the top, the best that we can bring, and then together we're going to make progress, as I believe we have. And the last issue, I don't need to expand that for you. Cancer, per se, is paralyzing when you hear it. Brain tumors is a terrible, scary thing to hear, being told you have one. And so there is a real psychosocial dimension that affects us, affects our family, our caregivers, our friends, our kids. And so how do you deal with that? And what's our role on the medical, scientific side to help deal with that? So again, these really do apply to practically every aspect of what we do at MD Anderson. So this is from the American Cancer Society. They publish every year the cancers. And yes, Jennifer is a breast cancer specialist, and you could see in women it's a very, very prevalent, 230,000 new cases per year. This is in 2014, and numbers are about the same now. So they talk about the big 4, prostate and breast, lung and colon cancers. And they are big 4 because numbers speak loudly. And for me, working in the brain tumor field, I look at this slide and the top 10 cancers in men and women, I don't see the brain. So when I speak about a neuro-oncology program, I emphasize that there are huge numbers that don't show up here and require a truly expert multidisciplinary groupings. Here are just examples of primary brain tumors, primary brain tumors, 40,000. Metastatic brain tumor, those are cancers, whether breast or lung or melanoma, skin cancer that travels to the brain. Well, who's going to take care of these patients? You need a neurologically trained expert on the medical and surgical and radiation side. 100,000 patients per year. Spine metastasis, you will know where the spine is. And when you have a metastasis that destroys the bone of the spine, well, guess what? The spinal cord gets compressed, and the patient may become paralyzed or lose bladder control, sexual function, and you name it. Serious problems. Who's going to take care of these patients? Neurologically trained doctors who understand these problems and have the tools and the techniques to help them. So I show this slide to say the numbers are staggering. but they don't show up on the top statistics. And that's why, again, we felt when we started our program at MD Anderson in 1990, was that we had to bring all these experts to work together to help manage problems that on the outside may not be readily managed, and you saw Anthony's example. And so look what happened to our program from 1992, just steady growth. I stopped counting because the need is out there. You bring the expertise, you bring the effectiveness, then the need is there, and patients who need those services, if they are lucky enough to find the place, they will come and they will have the care provided. The technical challenges, again, I think you saw an example with Anthony. That was not an easy surgery. So you need anatomic skills. Brain is a complicated organ and a lot of important function there. Surgical skills, technologic skills, the tools that we use now in the operating room or outside of the operating room, even in research, are incredible. The molecular biologic skills, you can't anymore say, take 2 aspirins and call me tomorrow. That won't do it. It's much, much more complicated than this. We're using viruses to kill brain cancer cells. And of course, interpersonal skills, we should never forget that is needed. So, the brain is like in space. You can get coordinates and use a GPS, and you can, like Anthony's tumor, pinpoint exactly where the tumor is and not get lost, because nobody has X-ray vision. And here's comparison between how to go to the moon and how to go deep in the brain. Same principle, X, Y, and Z. Coordinate, you find a spot, you go after it with precision. And here's a navigation system. We started using this one I used on Anthony in 1994. It was a beta test site. We got it from Toronto. And since then, of course, it moved into much more sophisticated LED and whatever, but it's a GPS, like in your car, but precisely leading you in the brain. Look what happened to, in 1994, I probably used it, 12 times. Now we're using this GPS over 700 times per year, so it becomes a second nature because, again, we don't have X-ray vision. We need that technology. It's not a gimmick. It's a real advance that helps us do more precise surgery and safer surgery. Ultimately, we're able to convince our administrator to invest $9 million in this so-called brain suite, which has an MRI 1.5 Tesla, that's excellent magnet, which is what we use to scan our patient on a regular basis. So we can do it in the operating room. And a quick example of this physician came from another state, had this big tumor. I operated on him, and I have a lot of experience operating on these patients. I thought I had it all out. And so part of the study, and we did that prospectively, was to, when we think we're done, we would stop, tell the technician in the operating room that we're ready to image the patient, and we had to fill a form that says how much of the tumor we thought we removed. I thought I got 100% of it out. Well, guess what? I left 20%, here's volumetric measurement, 81% of it was removed. I left 19%. With a tumor like this, 19% is not going to work. These are very resistant tumors. You have to get to nearly 100% removal of the enhancing mass. And so in the operating room, we had this feedback, we had this information. We didn't send the patient to the floor, and the next day did the scan, which the way we used to do it. And so I was able to complete the job right there, right then. And so we, of course, published many papers on that and demonstrated the effectiveness. Issues of curability, you've already heard my comment on this. Most malignant brain tumors on an average, do not survive 15 months. Then this is totally unacceptable. So just think of the incredible potential for therapeutic innovations, and you will hear some of that applied to other cancers. Of course, we are also working to apply it for brain tumors. It does take a village. We were fortunate to consolidate our research program for neurosurgery, neuro-oncology, neuropathology, and radiation oncology. Again, look at the multidisciplinary coming together for research. This is not for patient care, it's for research. We occupy the entire 5th floor of the George Mitchell building, which is a state-of-the-art genetic building with an incredible vivarium where animals are cared for because we need animals for research. And so we have 100 individuals who are working. Some are technicians, some are students, some are postdoctoral fellows, and of course several of them are physicians or Ph.D. scientists. So that's what it takes. This is the largest group in the country working on brain tumors to make advances. Incredible science fiction type work has taken place. Now these are common, and the geneticists among us use these animals, engineered animals, on a daily basis. But back then, when this study was done, Eric Holland was one of my faculty, a very, very prominent, he's in Seattle now, very prominent physician, scientist, neurosurgeon, showed for the first time that you can, in specific brain cells, this is the science fiction part of it, specific cells in the brain of this mouse introduce 2 bad actors, RAS, an oncogene, and AKT, 2 bad molecules that make cancer really bad and resistant to therapy and suppress immunotherapy or the ability of the immune system. And so he demonstrated that if you combine those 2, you create this most horrible tumor called glioblastoma. John McCain died of just a month ago. So now we know what are the mutations that are occurring, but we don't know why. We don't know why they're occurring in patients. So a lot of research is going on that, and I think Dr. Futreal is in the leading edge of that type of research. And so, again, I move on. Innovative clinical trials, and you're going to hear of some of those trials in a minute. But this is what is called today precision medicine. What do they mean by precision medicine? Well, the basic principle is you want to know what are the molecular and genetics mutations or aberration that are occurring in any given cancer in one individual person. And then you have to identify those targets, have the drugs or combination of drugs that go after that target, see the response. Patients, some will respond, some are cured, some don't respond at all. Why? Why this difference? Well, this is where the database comes in, and the database is going to sort through artificial intelligence or big data or whatever term is being used now. And based on that, it goes back to inform what happened to the patient. So that is precision medicine. Now, it's easier said than done. Most patients don't have a recognizable mutation, or they have mutation that we don't have drugs against. So those are really the big challenges that we are facing and we're trying to solve. So we felt that to help our team move forward and advance, we needed to build infrastructure that are needed by each program. Those are 3 examples. Tissue bank. When we take a tumor out of a patient, this is gold. This is very valuable information that, again, for precision medicine, will inform us what's specific, what's real unique about this tumor in this individual. Because ultimately, that's the only way we're going to move forward. If you take a shotgun and kill everyone, it's not going to work. You want to be much more precise, much more targeted. So tissue bank, the database I've alluded to earlier, and the animal core. Those three, they cost money to have these available to our physician and scientists to help them do. And so they used our tissue bank at NIH when they did the TCG, the Atlas of brain tumor cancer. They created an atlas of all the mutation in these tumors by sequencing 200-some tumors. Well, half of these tumors came from our tissue bank because we invested in it, and we had excellent tissue that we saved and we gave to NIH when they run that. So again, value of investing in infrastructure. Database, again, Dr. Suki happens to be a top leader. She's an epidemiologist, and our look at the number of patients that we have now in our database. Gold mine that you can go back and mine and get data on. And I'll skip that. And animal core, I've already showed you how important animals are in doing research. And here's a model that we have used. And I demanded a yearly report because we pay for technicians, and that costs us money. I want to know, are we using our money wisely? Look in yellow here. In 1 year, 1,500 animals were tested in our core facility to help 10 and 12 investigators test new drugs, new viruses, and whatever. So again, this helps other labs not to have to reinvent the wheel, learn the techniques, and they may not do the proper animal experimentation. So having that for them is very helpful. Multidisciplinary organization, that is absolutely a key. I said earlier, not one specialist. Surgery is not going to solve brain cancer. It's going to help, but not solve. Medical intervention, drugs, is not going to solve brain tumors. It's going to help. Radiation, and you name it. So it's by bringing everybody together. Unfortunately, as I said, in medical schools, we are taught to live in silos, radiologist in radiology, medical doctor in medicine, surgeon, pathologist. That vertical layers is not what is going to solve the problem. It's the horizontal layer. And really, MD Anderson was the first place, and is recognized, the first place for multidisciplinary delivery of care. But it's not enough to have multidisciplinary delivery of care. You want a multidisciplinary integration of a program that includes other specialists, including research, because the only way to advance, integrate what we learn in research, bring it to the clinic. And here, this is our program, and I believe it's one of the best integrated programs at MD Anderson. And we, of course, have meetings like this, share ideas, share thoughts. And let me close, and I'm sure I've taken much more time than I was assigned. Let me close by, emphasizing the need for compassionate care. Again, I think, having been at MD Anderson almost 30 years, I know it's in our DNA. I know it's in our genes. It's in our volunteers' genes. It's the way we live, the way we breathe. And don't take it from me. Many of you have walked the halls and have dealt there. There's an incredible level of empathy and compassion, and it is needed, and it's a must. And so the patient is a whole. You are not, a brain or a breast or a colon. You are a human being. And so what affects this brain or this colon or this breast, guess what? It affects all of you. It affects all of your family and all of your caregivers and all of your friends. And so it really is an earthquake. And so look at the patient as a whole, provide compassionate care, meaning listen to the patient, hear what they're saying, understand what they're going through. Case management is very important. There are things, as physician, I cannot handle. Patient has a paralysis, we did surgery, they're doing fine with surgery, they're from out of town. What do? I send them to the hotel? but they can't walk. They can't go to the bathroom. We need case management. We need social workers. We need support staff who specialize in helping these patients, depending on their situation, deal with their problems. So complex. Rehabilitation issues, patients will have problems or may come with problems that we have to deal with, and support group is essential. And so here's Michael, 24 years of age, came, as you will see on one slide, from Oklahoma. His surgeon did a biopsy, and you may not see, but they did a biopsy up there, told him it's a malignant brain tumors, you have 6 months to live. 24 years of age, just think of your son. My son is older than 24. So 24 years of age, you're told you have 6 months to live. Who is God among us? As far as I know, nobody is God among us. We don't know. We do our best. Sometimes we fail, but sometimes we succeed. So he came to me. Obviously, he was down. He was depressed. Could see it in his eyes. But he wanted to fight. And he said, what do I do? So I looked at his scan, of course, from a neurosurgical standpoint, and I said, there is no reason why I could not take this ugly-looking tumor out. And again, I don't need to point to you that, all the white stuff is ugly tumor that goes all the way down to the corpus callosum, critical part of the brain. So without belaboring the point, I used the, magic navigation system and other ultrasound and other tools, got all the way down to the bottom of it, got a scan after surgery, got all the visible tumor out. Now, we all understand there are microscopic cells left behind that are responsible for these tumors coming back. So, as I said, surgery alone is not going to cure this patient. But without this kind of surgery, this patient has no chance of living. Certainly no chance of living 5 years. So, he did extremely well. I was so happy. I sent him for a picture. I wanted to document how well he did. And so he went to the photographer at MD Anderson. I wasn't with him. And here's Michael. Of course, I have his permission to show that picture. So Michael, 1998, right? Look at his sense of humor. He's telling you, hey, I just had brain surgery, and guess what? I'm not paralyzed. Because that was one of the risks of the surgery, was paralysis. And, he has staples still on, so it's very fresh. Look at his eyes. This is somebody, not only that has a sense of humor, but that is wanting to face life and to deal with the problem with confidence. This is what an integrated center of excellence can provide patients, is giving them confidence, giving them hope, because without that, well, guess what? It's 2 thumbs down. And so this is 1998. He sends me a Christmas picture in 2006. Michael is alive today. In fact, 2 years ago, they got a scare. His wife had headaches. And they did an MRI, they found something, and right away got in the car, drove down from Oklahoma to see me. It was a small, benign cyst, no concern, nothing to do about it. They went back home. So I know he's doing well, and his family is doing well. So let me close by saying that we are all technicians. This is a technical world. Technology surrounds us. Can't breathe without technology. So we're all technicians. But do we want to function as just technician that just presses button? Or do we want to use this technologic expertise and knowledge integrated with our other specialists to deliver a comprehensive disease management? This is where technology makes a difference and can add to our human interactions. And so the summary of our goals, and again, remember, this is not limited to the brain tumor program. This can be applied to every other program at MD Anderson, is patients' interest gets first priority. That's why we exist. We're not here to only cure rats and mice. We're here to help humans deal with cancer. Technical and biologic skills are maintained high. This is really getting very complicated, and we have to be able to understand and master those skills. Integrated teamwork is a necessity. In fact, without it, there's no future. And clearly, research will provide the ultimate cure because many patients today are not being cured. So put all that together, and you have a winning solution. So some of you know this sculpture from the art district in Houston. I use it to say I apologize. I played my own music here, but it's the music that I understand best, and I thought I'll share with you that experience. Thank you very much.
Thank you, Dr. Sawaya, for this very inspirational and actually comprehensive perspective of really how all of our cancers, all our disease-specific centers at MD Anderson operate, that is in a comprehensive and multidisciplinary mode.